Hey everybody, it's Dr. Wood, and today we're covering Chapter 17, where we're covering some anti-infective agents. So first off, what is an antibiotic? Basically, it's going to be any agent that we're using here to combat infections due to a variety of microorganisms. Bacteria probably being the most common ones you're going to run into, but certainly fungal infections, viral infections, etc. Later on in the section, we'll also talk about disinfectants, germicides, and other antiseptics that we'll also use in the medical setting. Now, as we tackle individual classes of antibiotics, and again, this will not be an all-exhaustive list, but some common things you're going to see with the majority of these antibiotics, and so it doesn't really bear repeating every time we cover one. Nausea, vomiting, diarrhea, very common with the majority of medications we'll talk about during this class here. Some of these can be more severe, causing diarrhea for sure, especially since a lot of them have the tendency to disrupt the normal gut flora. So the normal bacteria that normally grow in the GI tract can be killed off just like any pathogenic bacteria. And that can lead to some severe diarrhea in some cases, or even as a secondary infection, you can see C. diff, otherwise known as Clostridium difficile infections that can happen. It's what we call an opportunistic infection. Other things that can occur due to antibiotic therapy include things like photosensitivity, which is a particular problem here in Florida, given that we have a very sunny sort of state. Patients may be more likely to develop things like rashes and sunburns as a result of the photosensitivity, so we do tell them to make sure to cover up well. And then things like dizziness, headache, insomnia, pretty non-specific sort of symptoms there. And then any drugs may have the ability to cause skin rashes and eruptions, particularly antibiotics. And so these can lead up all the way to really severe, potentially deadly complications, things like Stevens-Johnson syndromes or toxic epidermal necrolysis. I won't get into the specifics of those here, but just know that the antibiotics can lead to some of these really severe skin reactions. Now, certainly how we classify our organisms here kind of falls under the field of microbiology, which you'll take specific classes on that should you need to. But again, we kind of will divvy up our organisms here based off of the kind of spectrum of activity of the antibiotics. So for instance, when we say antibiotics, more generally speaking, we're talking mainly about things that kill bacteria, but we'll also talk about antiviral agents, antiparasitic, antifungal agents, etc. That all have a very specific activity for one type of organism or another. And so it's important that when you're talking about microorganisms, they can be either considered pathogenic, meaning that they are disease-causing, something like, say, methicillin-resistant Staph aureus, or MRSA for short, or it could just be normal flora, right? So, for instance, we have lots of different types of bacteria living on us at all times, and that's totally normal because they normally don't cause much disease, and as long as the circumstances are not right for that. And how you further classify them will be based off of their shape or their morphology. So, for instance, you can consider them to become in cocci or bacilli shaped, etc. Another really important aspect here is the gram staining. So, whether they will pick up a certain type of stain, leading them to have two broad classifications called gram-positive bacteria and gram-negative bacteria. That's really important in terms of determining what sort of antibiotics are needed to cover those specific bacteria. We'll also talk about their need for oxygen. So in those cases there, you can have aerobic bugs, which will be the majority of bacteria that we'll talk about in terms of antibiotics. They also have anaerobic bugs, or bugs that grow in the presence of little to no oxygen. So for instance, anaerobes like to grow in the mouth. They like to grow in the GI tract. They can even grow in wounds and things like that, especially like a diabetic foot wound where maybe they have socks or shoes that are covering up those areas. You can see anaerobes growing there. And then another classification here will be what we call our atypical bugs. This includes things like Legionella. This includes things like Mycoplasma pneumoniae. Things that, while frequently can cause bacterial infections, they resist that normal gram staining, as I mentioned above. And so if you ever hear something like an atypical pneumonia, that's basically what we're talking about, is a pneumonia caused by a type of atypical bacteria. So our antimicrobials are designed to destroy the organisms, or in some cases just inhibit their growth. The main point there is that we allow our own host immune system, our own white blood cells, to come in and actually attack those organisms. So as long as we're inhibiting them from growing, for the most part, if you have an otherwise healthy individual, the normal host immune system will come along and destroy the bacteria. The drugs are just really trying to keep them from replicating. Some other cases, though, you'll find they're very good at just killing off the microorganisms entirely. And so you'll find this includes several different things here. So, for instance, natural antibiotics. These can be naturally occurring substances in the animal world or synthetic substances that will directly interfere with that growth. And they can be further broken down into things that are bacteriostatic, meaning they just inhibit further replication of the bacteria, or bactericidal, meaning they'll actually directly kill off that cell. So how we choose our antibiotics is based off of several things. So for instance, where the infection is actually occurring. So I will treat something like a pneumonia very differently than I would treat, say, a skin infection, because different bacteria are likely to be causing those infections there. And so based off of that information, we may also do things like culturing the site to see what kind of bugs are growing. And it would then be based off the sensitivity of those organisms to our antibiotics. So very frequently you'll have antibiotics that are completely resistant to a bacteria. You may have things that are totally susceptible, and we like to use those things that are susceptible because it's more likely to actually kill off or inhibit the growth of the bacteria that we care about. And so rarely do we ever give like preventative antibiotics or prophylactic antibiotics. One case where this would be the exception would be in surgery, where you're actually opening up a patient and exposing them to bacteria in the outside environment. And so we will frequently give prophylactic antibiotics in those cases there. So if you go to work in surgery or in anesthesia, you'll certainly see that. And when we talk about the activity of our antibiotics in terms of how many different types of bacteria they treat, we talk about the spectrum of their coverage, where narrow spectrum means they only cover a few different types of microorganisms, whereas broad spectrum means they attack a wide variety of organisms. So generally speaking, when we start treating a patient with antibiotics, we'll start off with a broad spectrum set of drugs, and then as we get the information back about what kind of bugs are growing, we'll actually scale that down into more narrow spectrum antibiotics. Now, other factors that come into play here are prescribing them only when it's indicated for a specific disease. So for instance, if I have a patient comes in with mild fever and runny nose, and it just looks more like a viral illness, well, I'm not going to give them an antibiotic prescription because it's not going to treat that, right? Just because someone has a fever does not mean that's a particular reason to begin therapy. There's a lot of reasons why patients may have a fever, right? But if they come in and they have a white count that's elevated, they have a fever, say they do a chest x-ray, and you see areas of consolidation, it makes you think that maybe this is a bacterial etiology. Let's go ahead and treat that, right? Really important that patients take the entire course that's been prescribed. The reason for this is they stop early. They can have either inadequate treatment to where the infection comes back, or potentially you start to select out for more resistant bacteria, and that can lead it to where, say an antibiotic worked the first time, but use that same one on a repeat course, the same disease, and may not work that time because it's now caused by a resistant form of that organism. And again, it's tempting for patients to stop taking their medications early because they feel better after a couple of days, but they need to continue on to do the whole course there. Now let's talk about our specific classes of antibiotics we're going to deal with pretty commonly. The first off is going to be our penicillins, and these are the first antibiotics that we really had, including the regular old just plain penicillin. And these really work by weakening the cell walls of the bacteria. Basically, it will cause their cell walls to break down to the point where they start to lyse out their contents, meaning all of their insides start to flow out, and that leads to eventual cell death. We tend to find that penicillins are resistant to a lot of the gram-negative bacteria, and you think of gram-negative bacteria like, say, in the GI tract, you think about them as causing a lot of urinary tract infections, etc., but they're pretty safe for the most part. One notable exception would be, though, that if they do develop an allergy to a penicillin, it is likely that they're going to have cross-reactivity with all other penicillins. So I'll show you a list of these in a moment, but for example, if someone has a true anaphylactic allergy to regular old penicillin G, and then I try to give them, say, something like dicloxacillin or piperacillin, you're going to find that they will have a cross-reactivity and likely have an anaphylactic allergy to that penicillin as well. Now, the differences between the ones that we have here are generally going to be their spectrum of action, meaning how many different types of bacteria do they treat. For instance, penicillin itself is relatively weak in terms of its spectrum of activity. It treats a couple of things really well, but that's kind of it. Versus if we were to have, say, something like piperacillin, which is very broad spectrum and it kills lots of different bacteria, right? And again, you'll get to feel for that as you work with these drugs in the future with whatever field you'll end up going into. One notable drug interaction I will make note of here is the possibility that the effectiveness of birth control pills tends to decrease. And this is not just an issue with penicillins, but it could apply to a lot of different antibiotic classes. And so the reason for that is because basically it will help to shorten the duration of action of those birth control pills. Normally, birth control pills are made up of estrogens and progestins, and it basically helps to stop ovulation in women of childbearing potential. And so if you give a penicillin and it disrupts the half-life of that drug, making it shorter, it increases the chances of a woman ovulating, and thus she may get pregnant. So there's never been a clinical trial saying that you absolutely have to use backup protection. However, weighing the risk versus benefits, the risk of having an unwanted child, or an unplanned child, I should say, versus the downside of using backup protection, I usually just tell people just to use the backup. Again, it's going to be a minor inconvenience, and if they're taking antibiotics, they're probably sick enough, they probably don't want to have sex anyway, right? So what are some of our different penicillins you might run into? This includes our narrow spectrum penicillins like the original penicillin G, penicillin V. Again, these came from molds originally, so some of you might actually have some growing in your refrigerators right now. You can go check that out, right? Moving on, then we have some more broad spectrum ones, things like ampicillin, amoxicillin, or sometimes we actually add something called a beta-lactamase inhibitor to our penicillin. So for instance, here we have amoxicillin plus clavulonate, or clavulanic acid is another name for this. Basically, this helps to prevent some of the resistance of bacteria that can develop to penicillins, and it makes this drug work that much better. So for instance, if someone has a resistant bacteria to amoxicillin, we can bump them up to using augmentin, and it actually works much better for them. And kind of the biggest extended spectrum antibiotic that we have in the penicillin class is going to be piperacillin mixed with a beta-lactamase inhibitor called tazobactam. This is frequently known as Zosyn and is a very broad spectrum, kills majority of bacteria that are out there, especially from a gram-negative sort of perspective. Now, similar to, and you can kind of consider the cephalosporins cousins to the penicillins, these are also work to weaken the cell walls, causing them to die. And so again, this would be an example of a bactericidal group of antibiotics. And so the way that they're going to be grouped up is into 4 different generations. You'll see these used quite commonly either on the outpatient side or in the hospital, and I'll give you a few examples of this in just a few moments. But these are nice as well because many of these will come parenterally, meaning we can use them via intramuscular or IV routes in order to treat more severe sort of infections. Now, it's important to note that there's a very small likelihood that a patient with a true penicillin allergy will have a cross-reaction to cephalosporin, but nowadays the risk is getting to be less than 1%. So generally speaking, just because a patient says they're allergic to penicillin does not mean they're allergic to cephalosporin. That's important because a lot of providers will be very hesitant to do so. And so when I'm in the ER setting, I frequently say, well, let's try test dose here in the ER, and if they have a reaction, then we'll be able to treat it here, right? And so that usually helps the providers feel a little more comfortable. They give a dose, the patient has no problems, and then they go home with a prescription for that drug. So just something to note there. Also, if you have a patient who says, I have a penicillin allergy, the most important question to follow up with is, what was the reaction? Very frequently they say, I had vomiting, I had some diarrhea. Not really a true allergy, in which case they can certainly receive a cephalosporin. Okay. Now, some cases you may find cephalosporins can intensify bleeding tendencies, especially if a patient is on a blood thinner, for instance. So that's one thing you would want to note for some of your patients. And in general, just like you can tell a penicillin is a penicillin via the cillin in their name, you can always tell a cephalosporin with the Ceph or CEF or CEPH that's in the name. So just to give you an idea of the different varieties in terms of generation here, you're going to find that the first generation, these are generally pretty good for gram-positive sort of infections. And as you go up in generation, you get better gram-negative coverage. So the first generation obviously were first around. This includes things like cephalexin or Keflex, which is a very common outpatient prescription for things like urinary tract infections. But if you work in the hospital, or especially around surgery, you'll see cefazolin or Ancef is used in almost every single patient, mainly because this is a prophylactic antibiotic they'll get within an hour of their incision time, and that way it prevents any bacteria that might be growing on the skin from getting into that wound and causing an infection. Moving up, you have things like cefuroxime, cefotetan, and second generation. Third generation, this is notable because ceftriaxone lives here, or Rocephin. Some of you may have heard this name before. This is like a go-to workhorse sort of antibiotic via the injectable route, and so you'll see this used a lot if you have any interactions with the hospital setting. Also Ceftonir in the third generation. And then for a fourth generation, this includes Cefepime, which is kind of like pretty similar in activity to piperacillin and tazobactam, very broad spectrum. Again, this is not an all-inclusive list, and that's going to be the same for any of the classes we're talking about here. It's mainly just to get you familiar with the sort of the most common examples of these antibiotics. Up next, we have our macrolides, another really broad spectrum type of antimicrobials. And in fact, these ones actually sort of have coverage against atypical bacteria. So this is why you see a lot of macrolides used for things like pneumonias. Now here it can be a little difficult with the names, because just because you see a mycin on the name does not mean that it falls into the macrolide category. And I'll show you a few examples of this in just a moment. But just be careful with the names in general. Now, we'll see here that erythromycin is going to be a pretty common example of a macrolide, generally pretty safe, and is a good alternative to certain infections in patients who cannot receive a penicillin. Be aware that they can cause a lot of drug interactions. These inhibit many liver enzymes and will cause the metabolism of other drugs to slow down, which can lead to toxicity from those drugs, so just be aware of that. The way that these work is that they're actually going to inhibit bacterial protein synthesis, and so that way the bacteria is going to be prevented from continuing to grow and replicate, and so these would be examples of bacterial static sort of antibiotics. The three that fall into this category are going to be erythromycin, azithromycin, which is otherwise known as Zithromax, or if you ever hear of a Z-Pak, this is what the drug they're referring to, and then finally clarithromycin or Biaxin. Up next, we have the Tetracyclines. This is another broad spectrum set of antibiotics, pretty old school set of drugs here that also work similar to the macrolides in that they inhibit bacterial protein synthesis. Now, in terms of adverse reactions, there's some notable things here, including a lot of photosensitivity, so be careful with your patients out in the sun. And then also it can actually stain developing teeth. So if you have, say, for instance, children who are on this for, say, over a couple of weeks, you can actually see their teeth being stained. And I'll show you a picture of that in a moment. And because of that, and this is because the drugs actually bind to calcium, which we know there's a lot of calcium in our teeth. There's also a lot of calcium in the bone, and so this can actually cause issues with developing fetal bones. And so this is why these drugs are contraindicated in pregnancy, meaning that pregnant patients should not receive this. And then these are usually going to end in cyclin, so that way at least know that they fall into this category here. But big patient education points is that you do not want them to take tetracyclines with any calcium supplements, milk products, iron, anything else that could bind to the medication, because that'll prevent it from being absorbed, and then it doesn't work. Then the infection doesn't go away, right? So it's really important to make sure they're educated not to mix these drugs with these substances. Here's an example of the teeth staining. You can see here sort of a dark brown coloration. You can see here the oldest set of teeth as they came out were unaffected, but then as the drug got introduced, you start to see the tops here being more affected. The three that we'll talk about today that fit into this category include tetracycline, we have doxycycline, and then minocycline. Another common place you're going to see things like minocycline and doxycycline being used includes for acne. So some of you may have possibly been on this during, say, high school or during your formative years in treatment of that. Now, up next we have the aminoglycosides, and these are actually interesting because although they do inhibit bacterial protein synthesis like the macrolides and the tetracyclines, these are actually bactericidal. So these are really good for really serious or life-threatening infections. So if you end up in the intensive care unit, you might end up on an aminoglycoside. Things we do have to watch out for is they can be nephrotoxic and ototoxic, meaning they can hurt the kidneys, leading to decreases in creatinine clearance or decreases in kidney function. And they're ototoxic, meaning they can actually affect the cochlea, affecting the hair cells in the ear, such that you have hearing issues that develop there. So if you ever hear a patient who's on one of these drugs and they start to complain of maybe a fuzziness in their hearing or a ringing, this could be evidence of that ototoxicity. Topically, we may see these being used occasionally, especially for ear drops and things like that. Really no problems there. It's really the IV doses that we start to worry about. And so if you have a patient who complains of dizziness, tinnitus, hearing loss, anything like that, definitely need to make sure they follow up and get changed to a different medication potentially. Three drugs that fit into this category include amikacin, gentamicin, and then tobramycin. So again, just because you see a mycin on the end of the name does not mean it's always going to be a macrolide. Here it can be an aminoglycoside as well. Up next, we have our Fluoroquinolones. These are another set of broad-spectrum antibiotics with pretty mild side effects for the most part. These actually work via a totally different mechanism than what we've seen already, whereas penicillins work on the cell wall and your macrolides work on protein synthesis. These actually work on something called DNA gyrase. And so normally DNA comes in a very tightly packed helical structure, and in order for enzymes like DNA polymerase and things like that to work on it, it has to unwind, it has to relax in order to open up those double strands of DNA. And so this is where DNA gyrase comes into play. It helps with unwinding by causing these kind of single strand breaks in the DNA. And so what happens is that when you inhibit this enzyme, basically the DNA is unable to unwind or rewind itself efficiently. And so the bacterial cell detects that and says, hey, there's too much DNA damage going on here. Let's go ahead and trigger off apoptosis, or that programmed cell death, basically cell suicide. And so that's how the fluoroquinolones are going to end up working. These are another set of products you do not want to take with milk, antacids, iron supplements, etc., because they will also bind very similar to the tetracyclines. These are going to be drugs we typically do not use often in kids less than 16 years of age, mainly because this can lead to things like tendon damage and can actually lead to severe tendinitis or potentially a rupture of the Achilles tendon. That's happened rarely, so we typically avoid these in kids unless we have to use them. Some representative drugs in this category include things like ciprofloxacin, which is Cipro, levofloxacin, otherwise known as Levaquin, and then moxifloxacin, which is Avalox. Next, we have our sulfa drugs, and so these are actually going to be working to slow down the growth of bacteria by actually inhibiting the bacterial cell from using folic acid. Normally, we need folic acid for things like producing new DNA base pairs, new nucleotides. We also use it for things like red blood cell formation, and so these drugs will be specific to working on the bacteria such that they cannot utilize folic acid, and thus they can't produce new DNA, and then eventually lead to cell death. And you'll see this used all the time for things like skin infections. You'll see them used for urinary tract infections. There's a lot of uses for the sulfonamide drugs. These also may cause photosensitivity, so be aware of that. And again, always let your patients know, especially for UTIs, that to take the full course, because otherwise they may get a resistant infection when they come back a few days later because they're starting to have their urinary symptoms again. So make sure they take the full thing. And then allergies to sulfonamides are relatively common, so you always want to be careful if a patient says they have a sulfa allergy. They're probably talking about the sulfonamide group of drugs here. And the main ones you're going to run into are going to include things like sulfamethoxazole and trimethoprim. This is a combination drug. They both kind of work in that same folic acid pathway. And otherwise, this can be known as Bactrim or Septra. And then sulfacetamide is another common one you'll either see as an eye drop or potentially as like a lotion for topical use. Other antibiotics you may run into include things like vancomycin. Vancomycin is a great gram-positive killer. Be aware, though, that especially when it's being used for those serious life-threatening infections, you can see some things like renal toxicity, similar to the aminoglycosides. But this is most often used for treating MRSA, or in patients maybe that are allergic to penicillin, but this has really good activity against MRSA or MRSA. This is probably going to be the first-line drug you're going to see used for that bacteria 9 times out of 10. Another common one you may run into includes metronidazole or Flagyl. This is actually used against certain protozoa and has really good activity against anaerobic bacteria, meaning things that grow without oxygen. And so this is used for treatment of Clostridium difficile. So if you had a patient who was on an antibiotic and they developed very severe diarrhea, and then you test them and they have an antigen positive for Clostridium difficile, then you might put them on Flagyl in order to treat that. And then for topical antibiotics, things like your Neosporins and your double antibiotics and things like that, typically they're going to contain either one or all of the following, including neomycin, bacitracin, and or polymyxin B. So a lot of those topical antibiotic ointments you may put on the cuts and scrapes and things like that usually include 1 or 2 or 3 of these drugs here. So to switch gears a little bit, to switch to different types of bacteria, we have things like Mycobacterium tuberculosis. You may have heard of tuberculosis and you think about it in terms of affecting the lungs, and that's certainly the most common place for that to manifest. The interesting thing about tuberculosis is that it can lie dormant for years. It can just sit there in the lungs, not really doing anything. And then when the immune system gets taxed or is weakened, that's when it goes into full-on growth mode and can cause tuberculosis. And because of issues of patients not being compliant to treatment, we are starting to see more resistant strains emerging, which is a problem here. And so a lot of times we'll see that treatment for this bacteria tends to go on for a long period of time, whereas normal bacterial infections you may treat for 7 days, 10 days, 14 days. This one you're going to be treating for months potentially because the bacteria grows so slowly. And over the course of months and months and months, you have to keep giving the anti-tuberculosis medications there. And in fact, some patients may be on 2 or more drugs for months just to prevent that resistance from emerging. Now, the reason why patients are developing more resistant bugs is mainly due to inadequate drug therapy. Either they're not on enough medications or they have poor compliance, meaning they don't take the medications like they should. And if you think about who gets tuberculosis, it's mainly patients who are immunocompromised, meaning they have poor functioning immune systems, or they are in areas where they may be exposed to other people with tuberculosis in close environments. So you typically think about patients maybe with HIV developing this because they're immunocompromised. Homeless individuals frequently develop tuberculosis just because they're around other people with TB, and so it can be really difficult for a lot of them to stay compliant with all their medications there. So it's why education is super important for those patients there. And you'll see for a lot of antibiotic prescriptions, you only give 1 antibiotic to treat that infection. Here we actually have to start off with 4 drugs, including isoniazid, rifampin, pyrazinamide, and ethambutol, and then based off of that, then you scale it back to 2 drugs after a couple of months or so. And so this is really important that they take all of these. The problem is there's a lot of side effects too. And so, for instance, isoniazid can cause some neuropathies in the hands and the feet. Ethambutol causes vision changes. So because of that, that's another reason why patients don't take the full course like they should. Now, when dealing with fungal infections, again, these are going to be completely different than treating a bacterial infection, mainly because their morphology is so different there. And so we're going to find that normally fungal infections are staved off because we have a good, competent immune system. However, for especially individuals that have poor immune systems, this is where we're going to find that fungal infections are more common. And also, they like to live in moist, warm, and dark environments, which means the feet, inguinal areas, underarm areas. Think about diaper rash is frequently caused by Candida, which is a type of fungus. You think that basically that entire environment described right there is behind a nice wet diaper. So again, very common, especially over-the-counter sort of treatments we're going to be finding for these infections. Now, again, you're going to find that patients who are on pretty serious immunosuppressants, things like chemotherapy, things like radiation, they may be more likely to develop this. But the most common thing you're going to run into, especially out there, and say if you're working in urgent care or a primary care office, are going to be run-of-the-mill stuff like ringworm, athlete's foot, or things like thrush infections in the mouth. You may find candidal infections in the vagina. Those are very common things that will typically be treated by over-the-counter medications. Now, again, depending on the severity of the infection, you may find that you either need full-on systemic therapy or topical therapy may be sufficient. So, for instance, athlete's foot typically doesn't require oral therapy. I can just put someone on topical cream, and that's usually good enough for it. Versus if I have, say, a patient with AIDS and they develop a systemic fungal infection, I'm going to need systemic antifungals for that. And so they fall into the same categories as the antibiotics, where they can either be fungicidal, meaning they kill the fungus, or fungistatic, where they actually inhibit fungal growth there. Okay. Most of the topical medications available tend to be over-the-counter, and then if they need to be used more systemically, that's mostly going to be for prescription-only use there. Okay. Now, some typical antifungal agents you'll run into include things like fluconazole, amphotericin B, terbinafine, clotrimazole, and miconazole. Usually, if you see an azole on the end of the name, it's probably going to be an antifungal drug, 9 times out of 10. Now, getting into viral infections, you're going to see that, again, you have to change your treatment completely because things that work for bacteria do not work for funguses, and they do not work for viruses. And so because of this, you're going to find that viral infections can be sometimes difficult to treat. And in fact, many of them we cannot provide a cure with medications alone. We can only suppress their reproduction and hopefully prevent an outbreak for your patients, but ultimately we cannot cure them for a lot of different viral diseases. We're certainly going to be seeing that resistance to antiviral drugs is becoming more and more of a problem as time goes on. And the 2 major classes we're going to talk about here is going to be non-HIV infection medications and then specifically HIV. Because that treatment is so different, we'll kind of break that up into its own class. So the common antivirals you're going to run into include things like acyclovir, valacyclovir, and ganciclovir. Certainly there are others, but these are the most common ones. You'll find that acyclovir and valacyclovir are very commonly used for things like herpes simplex, genital herpes, shingles due to varicella. Those are all super common reasons why patients may be taking one or both of these drugs here. Ganciclovir is typically reserved for immunocompromised patients who are getting some more serious viral infections, things like cytomegalovirus, which can be deadly in some cases there. And essentially how these drugs work is they inhibit the viral DNA production. They basically prevent viruses from developing their own DNA, and thus they eventually die off. It's really important you tell your patients to drink these drugs with plenty of water. What tends to happen if you don't, especially if you're sick and you're not feeling well, you may not get a lot of fluid in. Things like acyclovir can actually crystallize out within the kidneys and in the actual renal tubules, and that can lead to some interstitial damage leading to kidney injury. And so that's why I always say drink plenty of water anytime you're on one of these antiviral drugs. Now getting into HIV antivirals, and actually a better thing to call these would be antiretrovirals, because HIV is a retrovirus. We know there's no cure, but we are starting to see that we have really dramatic advances in our drug therapy, meaning that, if you look at someone who had HIV back in the 80s, they had basically a death sentence handed to them. Nowadays, though, patients with HIV are living for decades longer than they used to, which means that they are now developing actually chronic diseases that they never used to. So now we have to start worrying about HIV patients with diabetes, with hypertension, with heart attacks, because they're living for longer, and that also means that they have more complications from the medications that they're on, etc. Not only that, but their drugs cause a ton of interactions as well. So these can be really difficult to tolerate drugs. They also tend to be high cost in a lot of cases there. And it's not like you can just be on one medication. Frequently, you have to use what we call a cocktail. That defines several medications that work well together to work against that virus. HIV tends to be something that develops resistance quickly, which is why it's really important that anytime you prescribe new drugs to a patient with HIV, they have to be ones that they've likely never taken before, because typically the virus is going to become resistant to things they've already been on. So kind of switching gears and going to chemical agents used either as antiseptics or as germicides or disinfectants. Kind of the different terminology here was that antiseptics are going to be good for reducing, preventing, or inhibiting growth on the skin and mucous membranes without necessarily killing them. So these are going to be really good for, say, prepping an area for surgery or something like that. Whereas disinfectants are going to be used on inanimate objects. So for instance, if you're cleaning your kitchen counters or cleaning a hospital room or something like that, this is where disinfectants are going to be really useful. They're really too toxic to humans, which is why we don't use them for them, but certainly on inanimate objects, it's no problem. And then sanitization is just that process of cleaning and removing dirt. So in terms of antiseptics, typically things like iodine preparations, like betadine or tincture of iodine, is typically used, especially for getting skin prep prior to surgery. It's important to note, though, is that allergic reactions are fairly common, so you do want to at least be aware of that and ask a question before they receive this. But again, a lot of patients get this prior to surgery when they're getting prepped. That helps to keep the area sterile, so that way bacteria do not kind of get into that site of and cause an infection. Alcohol is another really common one too. I'm sure many of you have seen alcohol dispensers as you go along about your day to disinfect your hands. Sometimes they can use this for surgery or for injections. You may see alcohol being used prior to starting an IV site. Most of the time, this is isopropyl alcohol, or rubbing alcohol is another name for this. That's usually a 70% solution that's bactericidal. And then the area should be air dried, which is pretty quick since the alcohol will evaporate pretty quickly. Other antiseptics you may see being used include things like hexachlorophene, hydrogen peroxide. Now, hydrogen peroxide is important that you only use new bottles of this stuff. A lot of times patients will have bottles of hydrogen peroxide that have been sitting around in their medicine cabinet for years, and it tends to break down. The chemical structure of hydrogen peroxide is H2O2, and that usually breaks down into water and oxygen pretty quickly over the course of months to years. And so it's important to make sure you do have a new bottle that you're using there, which shouldn't be too big of a problem in the hospital. And then sometimes we'll use things like silver preparation. Silver itself has an antibacterial type property to it, and so we may use this in the eye or potentially on burns or on werewolves, as the case may be. And then, as in terms of disinfectants, these are only going to be used on inanimate objects, and they basically sterilize or destroy all microorganisms and spores. These are super important to make sure you keep areas clean, especially, say, if you're moving patients from one room to another. You want that room to be sterile, so that way they don't pick up the bacteria that someone else left behind. And typically, we use a pretty dilute sodium hypochlorite solution, which is another name for bleach. We can use that to basically clean the surfaces, and usually make it every 24 to 36 hours, because otherwise it tends to break down over time. Other things that could be used as well include things like boric acid. They can either use as an irrigant or an eye wash potentially. So that's it for the anti-infective sections. If you have any questions, let me know, and I'll talk to you soon. Thanks a lot. Bye.